Thank you, ma'am, for those kind words of introduction. I am aware that I begin with a handicap, in the sense that it is eating into your chai or tea time. So my session, according to the schedule, is over before it even begins. But it's an interesting topic, and I would like to introduce you to the many things. Many of those who are not in community medicine will find it interesting why this topic is there. So this is the outline of my session, why and what is community-based medical education. The competency-based medical education and community-based medical education, the relationship, and the need to align community-based learning experience ultimately to produce job-ready graduates. And what was the tagline of my topic given was enhancing holistic community-based learning by students. Way back in 1984, Harden et al. Proposed the SPICES model. It was at that time the educational strategy propounded. Student-centered, problem-based, integrated, community-based, electives, and systematic. And he proposed a shift from the teacher-centered, information-oriented, discipline-based, hospital-based, uniform curriculum, and apprenticeship curriculum. Now, if you ask ourselves, where are we now? 1984 was 40 years back. So things move a bit slow, but surely we are going into and steadily and focusing now to move away from hospital-based to community-based. Not in its entirety. Some medical schools in the world are entirely community-based, but we have to use the enormous learning opportunities that present in the hospital itself. But when we have to keep in mind that the statement or the purpose of the basic doctor or MBBS graduate is to produce the Indian medical graduate. And we are also aware that we are in the curriculum transition from the traditional curriculum designed by experts in the field and to community-oriented education. And community-oriented education begins with the design of the curriculum according to the needs, community's needs, not what the experts felt. So, community-oriented education refers to the objective of that curriculum. It is oriented and addresses the community's needs. And community-based medical education is part of it, of the community-oriented education, where the teaching learning activities for primary care are located in the communities. So community-based medical education, the learning activities, some of them are, the training occurs in the community. So we are familiar with the goals of MBBS program. So have a look at that quickly and see, especially this bullet over here, physician of first contact. Effectively as a physician of first contact of the community while being globally relevant. So that's a very broad perspective and objective that has been stated. So is our new CBME curriculum community-oriented or community-based? Reflect on it. Is it community-oriented? So objectives or the goal that we see on the screen, they are oriented to the community needs, preparing a physician of first contact. And so, but some of the activities happen in the community. So community-based education within the overall oriented to communities' needs. Way back, long back in the 1970s and 80s, many of us who are here, the old timers, we would have been exposed to the ROAM program, the reorientation of medical education. Because those times it was realized that teaching was entirely in the hospital, and so the students after graduation found themselves as a misfit and ran away from the rural postings or places where they were posted. And so the experts who wanted the education to shift from a hospital-based to a community-oriented one suggested we carry out some of the training in the primary health center. So even the specialists used to go and visit the primary health center and train certain competencies in the community or at the PHC level. Look at the outcomes and the roles of the doctor, clinician, leader, communicator, lifelong learner, and professional. Which of these is being addressed in the hospital setting? Patients, families, communicator with patients, families, colleagues, and community. To some extent it is happening in the hospital, but communication with families, with the community, the best situation would be at the community setting. Then a professional, responsive and accountable to the patient, community and profession. So that will happen only when the students are taken to the community and they will be learning and given a chance. So some of these, it's possible for the community medicine department, but together with teams, they need to take the students to learn and observe the tasks being carried out in the community so that they can correlate. Otherwise, the teaching of the subject becomes theoretical. To make the teaching community-based, how many of you are happy with the training that is happening in the community medicine or in the institution itself? Generally, the thinking, it's all theoretical, and students find it tough to relate to what is being said. So this can change only when they see the reality in the community. And also how the curriculum is being implemented requires to be redesigned, reoriented and implemented in a systematic way. Because now community medicine is synonymous with textbook of park. Students also don't call it community medicine, they say SPM. So and finally they read that textbook and that they can pass. So that's the reality, but we need to, if we want to make them interested and be job ready for doing the task in the community at primary care level, we have to take them and make them aware of and learn in the community itself. So to begin with, we have to do an alignment exercise within the institution. The curriculum has to be aligned, and this has to be made clear even to the students that you start with the professional task and bring to their attention that the graduate outcome, what are the graduate outcomes, and then the subject-wide competencies that are there. Fortunately, we have now the UG curriculum document available, accessible to the students, and we teachers must bring it to the attention that a particular competency is what they are going to learn when they go to a field experience. And we need to design the learning experiences through a curriculum matrix linking learning experiences to competency progression. So if we look at, we are mainly interested in making our graduates job ready. And what are the tasks of the medical officer working in the PHC? It says curative work, preventive and promotive work, national health program implementation, training of staff as well as people in the community, and administrative work. So that being the case, that should be the starting point, and we need to identify which of those competencies can be community based. So this is an example of community-based medical education matrix planning for each task. For example, identify and manage common important health problems. So what competencies are required for that? And then during which posting that can happen. The second task is to train, support and supervise other members of the health team. So how is that to be implemented? Validate and interpret data collection by health workers. So that is the important role of a medical officer at the primary health center. So unless the medical officer himself is trained to do those things, then he will not be able to supervise the work of the health staff. Implementation of specific national health programs to monitor them. What is being done now? So we need to take them for PHC visits, get the students to interview them and things like that. And of course, internship program, they are posted at the PHC. So these are the various, there is an alignment between the tasks and the planned learning activities. So I strongly recommend that within the department, when we plan out or implement the curriculum, we need to really evaluate and review what is being taught. And is it connected to making them job ready for the task of being a medical officer of the PHC or the doctor of the first contact. So we have the 5 years exposure from first year to the internship, and if we look at the tasks, they are targeted and distributed: care provider, leader, in different decision maker, manager, communicator. So when we look at all these tasks of the graduate, and then in the curriculum planning, we identify the learning experiences when these can happen in the time available in the timetable for them. I want you to think and identify what are the types of community-based learning opportunities that is happening currently. Think, write it down, check with people on your table, use the mic and let's have some interaction. Anybody? Okay, family adoption is there. That's because it is recommended by NMC. No other go. Okay, these are what the examples that are coming. They are related to the training that are prescribed. Okay, what else? Good. So literature classifies community-based learning opportunities into 3 types: service-oriented programs, research-oriented programs, and the core training-focused programs. Training-focused programs are the ones that fit into the curriculum and teaching schedule. And the concerned department plans the respective learning experiences to carry out and prepare the doctors for primary care. Now, service-oriented program. I want you to respond whether these are being implemented in your institution. Community development. Some of you did mention family and family adoption program, and one of the stated objectives is to improve or adopt a village so that at the end of the 5-year period, that village develops. Any other? See, community development, most institutions especially, have the additional responsibility, a corporate social responsibility. You are there existing as an organization, and people's expectations are high. In addition to providing health care of the tertiary care level, there is a social obligation also, and many organizations and institutions undertake projects, outreach projects, and there are developmental programs implemented through the urban and rural health training centers. That's already there. So to develop rapport with people in the community, both the urban and rural health training centers, in order that the people welcome the students when they go and knock at the door, there has to be building of trust, and they must get something out of it. So before that happens, there must be many developmental programs and activities that need to happen in both the urban and rural health training centers, apart from what you are providing through the outpatient services. So any such activity being done, please tell, so that there will be a wider dissemination of information in this audience. Okay, camp is a common thing that institutions find it easier to reach out to people in the community. But camp is often a temporary measure. Camp is a good thing to begin with. Okay, any other? Pardon? Cancer screening is a kind of an obligation. There is a public demand, there is a need, as well as the institution gains a lot of trust by conducting these special. It's not obligatory, it's not mentioned as a requirement by NMC, like the family adoption program. But screening for breast cancer or whatever, all kinds of things, when initiated, it contributes to building of trust and contributes to community development also. Any other? Okay. So early detection of disabilities, okay. Hearing. So these hearing, visual and other early detection programs are part of camps, or it could be adopted schools. So these are all extra activities which we call as community developmental activities. In addition to that, we have health interventions like school health and health outreach for elderly. Now the southern India population is all becoming mostly elderly. When you go and visit homes, you feel only the oldies there at home. The other generation people are almost very negligible. And yeah, palliative care is another emerging need, and the institutions rise to the occasion to provide palliative care to people in the community. So I am listing out these activities, developmental activities and interventions are happening, and it makes sense to take smaller batch of students when these activities are going on. And when they see their own role models providing health care in these settings, it enthuses them to and interests them to learn more, So it is a good opportunity to expand your community-based teaching activities beyond the usual training programs. So usually students observe, and when they are interns, we can involve the interns in actual conduct of these programs. So it's an experiential, actual immersion into their activity. Another thing we have to remember, there is a dilemma. When in the first year, for example, the students do not have the skills of diagnosis, and they have not yet learned about pathology and all those things. So how to use the student? So we have to remember that health results from development. So developmental activities, community development, better housing, better sanitation, improved water supply, education of the people results in better capacity to purchase food, better housing, and things like that. In fact, as part of our projects in the place that I was working, the objective of the project was improving adoption of family planning and adoption of small family norm by empowering the women, by encouraging them into community developmental activities or income generating activities. And as a result of improved income of the women, they could say no more children. So it is empowerment, and such projects are there. And when students see and observe the social determinants of health can influence the health, it becomes a good opportunity for them to connect between development and health. So better utilize, it is beneficial for the organization which organizes these services and develops. Because when family income improves, the families can not only they gain the trust of the organization providing the service or development, but their capacity to purchase the service, the fees also improve. So it's a win-win situation both for the institution as well as for the people. And this is easily observed by the students, and we need to focus on that and make use of all these opportunities. Another very important and useful opportunity is health education. So a lot of opportunities present to the students to be involved either in the OP itself or when the patient is waiting in the waiting area before entering the consultant's chamber. Those people waiting in the waiting area, their time can be used by encouraging the students to give health education. Of course, the students need to be trained in giving health education. And also similar opportunities to be given in the community. Community-based education can also be in health facility-based or community-based. So can someone in the audience look at these points, programs, and tell if they are happening in 1 or 2 sentences? Yeah, just tell what is being done and which area. Health facility-based at the urban and rural health center. Many institutions also have ICMR projects or Department of Science and Technology projects, or they interact with the health system, or some of the teachers are involved in program evaluation of the national health programs. Any other situations where in your organization this is happening? Okay, community-based research program, effectiveness, utilization, all these, if it is not happening, you should start thinking of taking up these activities. Because in many of the recommendations at the WHO level, it was felt that the teachers should be seen implementing these research and developmental activities. If they see the teachers only taking classes, then they can't connect. And so we should be encouraging the faculty to undertake both health facility-based research and community-based research. Research, we all know, it helps solve community problems. So when we are designing research projects for the students, help them to identify what is the problem and what research design they will choose so that it solves the problem. And then how will they measure whether the program intervention has been effective. So through simple community-based research projects, they learn various competencies needed for program planning, as well as identifying the indicators of success, as well as opportunity to plan educational program evaluation as an intervention to overcome or solve the problems. And the additional advantage is they can, once you charge them up, once you ignite the fire and interest, then they will be happy to do it on their own free time also, and at their own time and pace. Then we have the familiar community-based program that are mandatory, and there are opportunities for us to implement them, take them to these learning opportunities that are happening in the community. So when the students do the research and the activity in the community, they learn, and they are doing it in teams, so they also learn about leadership and development. So what needs to be done to make students' learning motivating? See, generally what happens when they are taken for community-based learning experiences, it's a picnic for them. It's just an activity, there's a bus ride, they go, and so to convert this picnic into a learning opportunity, we need to do certain things to make it effective in achieving the purpose of the visit. So make them aware that through the process of lesson planning, the onus is on us teachers to plan, those who are accompanying the students and supervising and guiding them. The teachers themselves must consciously do lesson planning, explaining to them before the students are taken for the field visit, the relevance, why it is being done, and the link to make them job ready. By going to the field, what is it that they need to do, how is it relevant to them for the job that they are likely to carry out, and link with the relevant prior activities that they learned, and briefing what to expect. So we have to have specially designed checklists and observation checklists or interview schedules that the students take to the community. They collect information themselves and then they present in the classroom, and there is discussion. So mentor and supervision presence of them is important. And then they measure the performance of the students and their participation as a team when they are collecting the information. So when students know that their performance and activities is being measured and monitored, then they will do active participation. So there are the basic principle involved is reflection on the experience. Encourage this to happen. So it need not be, reflection need not consume lot of time. It can be quick reflection and asking different students to reflect in say 1 minute. So a collective verbalizing of the reflection of different students helps them understand the varied nature of learning that happens. So asking them, what was the experience? Why did they go to visit the milk dairy or the PHC, what did they do? It helps them or boosts their knowledge retention. And then they observe, and as a result, the next part of the reflection is, so what? So what is in terms of how they, and what next is how they will use the knowledge gained to improve their abilities next time and their connection to their job responsibility as a doctor of primary care. So it improves performance and relevance. So the benefits of community-based learning for students, to the individual students, it improves their knowledge. It's a varied experience, and when they have gone through the experience themselves, then when we take a class or a lecture, then we can ask them to recall what they saw, and whatever words we speak, it makes sense to them. And you can ask them to recall and connect what is being taught, or in group discussion, they would have already seen and learned in the community, and so it becomes easy for them to discuss. So experiential learning, and it motivates them to learn what we are teaching. Otherwise, it is dull and boring. It also helps additional things. For example, situational learning, cooperative learning, the students learn from each other. They are sent out in teams and they learn from each other, and they form a community of learning. There is a debriefing session after the visit, and all that, it improves the learning. So to sum up, community-oriented medical education is to meet the community's needs. Our NMC curriculum of UG basic curriculum is a community-oriented curriculum, and some of the activities that are carried out are community-based, and it is important for the departments implementing community-based medical education to do actual mapping, so that you become clear that some of these important elements are not missed. Otherwise, you will be busy doing the routine things. So you need to do a matrix, and the community backward planning helps you to link with the ultimate purpose or the goal of education and training. And community-based is best learned experientially, and it can happen as part of the institution's service, as well as it can happen as a part of the research activities of the institution, as well as the training commitments which are mandatory. So these are the possibilities, and experiential learning, making them to reflect and capturing it in the logbook and the portfolio, where they actually record the evidence of having learned, and combined with assessment of that learning will ensure that they are job ready and competent. So the importance of community-based medical education is engaging with the community. That is a unique experience. It's a challenge. When the patient comes to the hospital, the patient is in need, in pain. Whereas when you are going to the community, you are the pain for the patient. So it's a challenge in communicating how to get the doors to open and find a foothold into their homes, and making the people welcome them, develop rapport. And in that sense, the family adoption program is consecutively visiting the same family. And over the years, it is possible for the families also to benefit from the visits by the students. So that is a indirect kind of payoff for the students, and students become their family doctors. So it's a good program, and we have been studying the various problems encountered, and with time we will have a better program. Thank you.